So thank you, Monica, for agreeing to talk at our monthly workshop. We've been doing this workshop for a very long time, and we try and bring relevant topics, but I suppose it cannot get more relevant than today's in the wake of COVID and the a lot of discussion around municipal public health across the world. The constituency of people who come to our workshop are a wide array of urban professionals, and therefore the subject of municipal health services is particularly is pertinent for them. So we're very happy to welcome today Dr. Monica Dasgupta from the University of Maryland. And welcome to all the attendees today who've come despite the slight change in time, or perhaps because of the slight change in time, a lot of people are able to attend this after work hours. I won't go over the details of the talk because all of you have obviously received the flyer and have a sense of the abstract. I'll hand over directly to Monica to start. If you want to say a few words before sharing your screen and getting our lecture underway, you're welcome to do so. So please, Monica, I'll hand over to you. And I'm going to keep time and indicate at about 40 minutes for you to wrap up, if that's okay.
Thanks, Mukta. Well, thank you for the invitation and for being flexible about starting late. Should I start the talk or?
Absolutely. Please do, please do.
Okay. Right. Does that show on your screen?
Yes, we can see it.
Great. So what I'm talking about here is public health systems. And as you said, Mukta, it's highly topical right now. And what I'm going to focus on is how important the organization of these systems is for regular public health services. I'm going to be talking about three different topics, really. Firstly, what is public health and why does it matter? Secondly, what's the background on the organization of public health services in Indian states? And what lessons can be derived from the way it's done in Tamil Nadu? And then I'll turn to municipal public health services. What are the key problems faced in urban areas? And what are some of the differences and similarities between how the Corporation of Chennai and of Delhi organize their public health services? Right, so what is public health? It's about preventing disease rather than treating the illnesses of individuals. Obviously, sometimes you treat illnesses, you need to treat illnesses in order to stop them spreading, but it's largely about disease prevention. And management is crucial. This is an interesting quote from the person who was sent when Japan, under the Meiji regime, was trying to modernize and industrialize. They sent people to different countries, and especially to Germany, to find out how they ran their, how they organized their institutions. And this man found out how the Germans organized their public health system. And he said, essentially, it's an entire administrative system that's organized to protect the public's health and to improve the nation's welfare. So there are three broad types of health services. Can you see the whole screen, or is the top cut off here?
Now we can see the screen. It's fine.
Okay. There are three broad types of health services. There's the clinical therapeutic services, i.e. the medical services, and those are focused largely on individuals' health And they're mostly what economists call private goods, i.e. it's the individual who gets to benefit from it the most. Then you have clinical preventive services such as immunization and antenatal care. And these are clinically delivered, but they are preventive services. And then to the right-hand side of the screen is the focus on population health. This is population-wide services to reduce exposure to disease. These are what economists call public goods. They're goods that no individual as such can consume without everybody having access to it. To give you an idea of what public environmental health officers in Europe were mandated to do, this is from the WHO European region, 1978. Basically check for water safety, food safety, safety of waste management, housing conditions, vector control, investigate and manage disease threats, occupational health, air quality, and so on. So basically all the conditions in which people live should be healthy. And this was really quite important in reducing mortality in the developed world. If you look at the figure for the United States, infant mortality rate, this is basically most of the mortality decline took place before antibiotics became available on a mass scale. It's not just public health, obviously, it's also improving living standards, nutrition, but public health improvements in sanitary conditions made a huge difference to this. And in Japan, which basically tried to replicate the German system, it helped to achieve high life expectancy, despite people having, on average, about just over 2,000 calories a day, which is similar to that of India. This is data from 1940, and what you see at the top is Korea, Japan, and Taiwan. So it's Japan and its two colonies. And then you see India with a life expectancy of below 35 for about the same caloric intake per capita as these countries whose life expectancy is far higher. And today, public health services form the core of the developed world's health services. It contributed to rapid mortality decline from the late 19th century. Basically, with their public health services, they shifted from controlling outbreaks, which they'd always done, to averting them. And today, public health authorities remain vigilant to prevent disease recurrence, such as malaria. Right here where I live in Washington, DC, they're very careful to prevent this from reverting back into a malarial swamp, basically through groundwater management. And this averts huge costs and creates important development infrastructure. What we found of late is that they're not nearly as effective at preventing diseases that they're completely unfamiliar with. And they need very much to improve their public health systems on those fronts. So just to quote Laurie Garrett, she says, focusing on clinical services while neglecting services that reduce exposure to disease is like mopping up the floor continuously while leaving the tap running. So that's where the huge costs come in. Nevertheless, medical services are often prioritized over public health services, even though public health services cost a fraction of what medical services cost. Part of the problem is that the results of public health services are intangible. Success is defined by an absence of adverse events. People rarely have a newspaper headline saying there was no typhoid last year, Or in New York, they rarely say, we haven't had any typhoid for 50 years. But if there's an advance in medical treatment, that's very big news. And everybody notices. And people get criticized for spending budgets for averting public health diseases because they don't see the benefits of the expenditure. It's a little bit like security services. The objective is to assure that nothing happens. There are also very strong incentives to divert budgets towards medical services because politicians can get easy approval by opening a hospital or starting a health insurance program. And this is strongly reinforced by private sector lobbies and by donor agencies. And middle-class citizens, they want government facilities to offer them the latest medical technologies. So they're also putting pressure to divert budgets. What's the relevance of this for India? India has a very high prevalence of communicable diseases. And this is exacerbated by rapid urbanization, which brings with it crowding, a lot of waste generation, migrants from many different places, bringing many different kinds of disease with them, slums, and a high density of activities which can generate disease around them, such as slaughterhouses, markets, and even hospitals. And there is in India a low focus on public health. The Indian government is extremely effective at controlling major outbreaks of disease. It's arguably been much more effective with COVID than many places here. And for example, it was very effective at controlling the 1994 plague. But it's much less focused on averting disease outbreaks. For example, they allow plague monitoring centers to lapse because they haven't had a case of plague. The 1994 plague, for example, arose because the monitoring center, which is just on the border between Maharashtra and Gujarat, had been allowed to lapse. They didn't feel the budget was justified. And the effect of all this is visible in child stunting. One way you can see it. India is a huge outlier in child stunting. As you probably all know. What's even more interesting is that the outlier part of it is the greatest in the highest wealth quintile. So if you look at the right-hand side of this thing, you can see that a quarter of children in India's wealthiest households are stunted compared to a third or less of that in Sri Lanka, Bolivia, Haiti, Honduras. And in fact, there's much more difference between rich households in India with other households around in other less wealthy countries than in the poorest quintile. Of course, in the poorest quintile, the outcomes are really bad. 60% of children are stunted, but so are they elsewhere. So, some of it is explained by the poor having less access to medical services if they're sick and to nutrition also. But in the wealthiest quintile, there's no other explanation except that they're getting sick unnecessarily. Now, in the wealthiest quintiles, people can access good medical care, so their children don't tend to have serious illnesses, and they rarely die of these illnesses. But subclinical infections also cause stunting because in a variety of ways, they reduce the absorption of the food that the child is taking in. And child stunting is shown in many studies to be associated with lower cognitive ability, lower lifetime earnings, and lower longevity. So this is not an unserious outcome. And indeed, historically, in the Western world, a key motivation for governments to improve sanitary conditions in slums was that they wanted to protect their elites. And this is sort of a nice quote, that people were aware that when people who live in very unsanitary conditions process their food or sew clothes or come to their houses to work for them, they can spread diseases to them. And they were motivated by this knowledge to upgrade slum housing and to install water, drainage, and sewer systems in slum areas. So now turning to section 2, I'd like to talk briefly about how public health services are organized in India, in Indian states, and what can be learned from Tamil Nadu. Basically, in India, before independence, the public health services, at the time called sanitary department, and medical services, at the time called the Indian Medical Service, were completely separate. And the doctors who led the sanitary department had better pay and faster promotion avenues than those than their peers in the Indian Medical Services. It was to motivate them because they, amongst other things, they can't derive income from treating patients. But in the 1950s, the central government asked the states to merge these services, which led to the atrophying of public health services because resources were diverted. Resources in the sense of budgets and staff were diverted to medical services with the pressure to provide tangible goods. Now, Tamil Nadu is unusual in that it retained the separation of public health and medical services. And this gives it a huge organizational advantage relative to other states. I'd like to preface what I'm going to say for the rest of this talk by saying the health outcomes you get on the ground are driven by all kinds of things, you know, what migrants are coming in, what the local conditions are. In the case of Calcutta, the fact that they received a river that's flowed through the whole of India, accumulating various kinds of industrial and other pollution. The conditions differ from place to place, so the outcomes also differ from place to place. What I'm trying to focus here on is the organizational advantage in responding to these conditions. The Tamil Nadu model is useful because it's easily replicable in other states. It has the same ingredients as all other states, the same structure of facilities, the same structure of staff. They organize these ingredients differently. They separate their medical officers into tracks. 99% work in the normal medical track. 1% choose to work in the public health tract. And after qualifying as doctors, they're given a short training so that they can administer, manage public health and primary health centers. This enhances the efficiency of both sets of services. And what's important to note is this is done within a budget that's similar to the Indian average. What you see here is the national health accounts for 2016-17, Tamil Nadu's per capita health expenditures, government health expenditure per capita. This is India, this is Tamil Nadu, which is slightly lower than the average for Indian states. And Kerala is quite a bit higher. And you get total health expenditure, which is government plus private health expenditure. Tamil Nadu has slightly higher expenditure than India's average, and Kerala has a lot higher. So basically what Tamil Nadu does is done with its organization is much more effective, but within the same budget, within the same government budget. And what distinguishes it? Their public health directorate, as I said, is separate from their medical services. It has its own dedicated staff with a tight management structure and a clear allocation of responsibilities from the state level down to grassroots level, and regular oversight of all workers, again, from the straight down to grassroots level. It has its own dedicated budget, so it doesn't have to wrangle about whether to continue to finance its plague center or have the health department buy a new CAT scan machine. There's no such wrangling. They have their own budget, and they can therefore hire the full range of support staff they need, such as epidemiologists, entomologists, people to catch rats and test them for fleas, you name it. And they are able to finance activities to avert potential threats and manage disasters. What's also important is that they have a Public Health Act, which gives them an umbrella mandate for public health action. Just to give you an idea of what this means, the head of public health in Karnataka state said that he wanted to do mosquito control in Bangalore airport, and he set it all up. He talked to the airport authorities and said, you know, we'd like to come. They said, sure, you know, they set a date. He shows up with his team, and security, airport security, turned them away. Because there is no Unified Public Health Act in the state, they don't have an umbrella mandate whereby they can say, sorry, you know, we have a mandate to do vector control everywhere in the state. This is what is important about it. Tamil Nadu's system has many strengths. I've already mentioned that they have no problem maintaining their monitoring centers for potential outbreaks. They also bring in other departments and the administration. There's an annual review to prepare for disaster management, and this involves the district collectors and other departments, such as the revenue department, the education department, and so on, so that everyone in the administration becomes familiar with the actions that are needed to protect public health and what they specifically themselves need to do if something arises. And this was manifested very clearly in their response to the tsunami, where the WHO went out of its way to comment on how smoothly Tamil Nadu responded to the tsunami with its intersectoral coordination led by the Public Health Department, and that they needed very little support from outside. So Section 3, Public Health Services in Urban India. I'll talk about some of the key problems faced by urban India, and then how this is dealt with in the Chennai Corporation and Delhi. The first key problem is weak links in the chain, a tendency to neglect the most vulnerable, and therefore contagion spills over to others. It's being neglected is bad for the most vulnerable. It's also bad for people who are not neglected. The second key problem is governance arrangements that reduce accountability. Some of this is as a result of devolution. Where service delivery was devolved in the 1990s to elected local bodies and with weak accountability mechanisms. And And the second problem is fragmented services to reduce accountability. So public health staff, for example, can do little to assure garbage removal. Chennai tries to mitigate many of these pitfalls, unlike Delhi. So the first principle of public health service provision is that outcomes are driven by the weakest links in the chain. You can be doing a good job in 90% of the population, but if you neglect 10%, there's going to be spillover. And there's very unequal distribution of civic services, as you all know, in urban India, in water, drainage, sewerage, garbage collection, etc. And the sanitary conditions for slum dwellers actually worsened between 2008 and 2012. This is from the NSSO. The percentage of slums with no toilets doubled, similar for percentage of slums with no drainage, and no garbage disposal also went up quite considerably. Contaminated environments affect our children, as we already discussed. Repeated infections expose children to stunting, and this affects all the people in the population, including the wealthiest. And this already I showed you. So governance arrangements that impair accountability. One is the devolution of service delivery and then the fragmentation of services. The 1990s constitutional amendment required states to devolve service delivery to elected local bodies. The idea being that local politicians are supposed to be responsive to their constituents, but the accountability mechanisms were very weak for both financial management and for assuring service outcomes. In a line agency, you have much tighter control and accountability. Secondly, this is especially bad for public health services because, as we discussed, politicians are demotivated because it's hard for them to claim credit for something that didn't happen. But also, very importantly, that disease threats are always shifting. And it's hard to respond if non-technical people are in charge because they don't understand the issues, and then the technical people will have to find ways of persuading them. You saw that here in the US, non-technical people being in charge when this pandemic broke out, and the technical people were, talking themselves blue in the face. They didn't make much headway. Secondly, services are very fragmented and poorly coordinated. We know this about urban India, but it's especially important for disease control because multiple services affect the outcome. If drains are clogged, it's hard to do mosquito control. And poor service coordination is also demoralizing for people. It's demoralizing for the staff because it hinders their work. It's demoralizing for citizens trying to get some accountability because it's not at all clear whom to hold accountable. Everybody can point to somebody else. And in the Municipal Corporation of Delhi, services are undermined by even more fragmentation. For example, in the Delhi Corporation, medical and public health services do not work closely together. In Chennai, they cooperate very closely at headquarters and in the field, all the way down. In the Municipal Corporation of Delhi, veterinary health is not under the municipal health officer, except to give people rabies vaccine if they've been bitten. In Chennai, the city health officer manages veterinary services, which means that they can work on controlling the transmission of zoonotic diseases and look at slaughterhouse hygiene and meat safety. It's just examples of how fragmentation can hurt. And very interestingly, both the New Delhi Municipal Corporation and the Delhi Cantonment, which comprise just 4% of the population of Delhi, they rejected this devolution of services under the constitutional amendment. Delhi Cantonment is managed by the army with some inputs from local elected representatives. The NDMC is managed by IAS officers who are nominated by the central government with some inputs again from local representatives. And in the NDMC, which of course is the locus of the central government that promoted devolution across India, their website says devolution is inefficient, and that's why they didn't go for it. They said they have to have efficient functioning of municipal services. It's obvious they need to do that because it's a seat of the central government. Both the NDMC and Delhi Cantonment are well-resourced, extremely well-resourced compared to the municipal corporation. But also importantly, they have very tight management structures. What you can see here is the National Urban Sanitation rankings in 2009-10, ranking of 423 larger and smaller cities. What you see here is Delhi Cantonment and the Municipal Corporation Council rank extremely high in terms of sanitation conditions. The Corporation of Delhi ranks abysmally low. And amongst the major metropolitan areas in India, Chennai ranked very high, 13 compared to Kolkata and Mumbai, and abysmal ranking here for Delhi. So this is the kind of contrast you can achieve by lack of attention to management. So what are some of the lessons from Chennai on mitigating poor governance arrangements in an urban setting? Firstly, they have a considered approach to devolution. They placed formal checks on elected bodies, and that's there, in their legislation. They retained professional management within the Chennai Municipal Corporation with clear lines of responsibility and accountability all the way down, and interdepartmental coordination. And very importantly, they have oversight and support by the State Directorate of Public Health, which has overriding powers to protect public health across the state. It doesn't matter whether it's in the largest municipality or anywhere, they have the power to protect public health. And if the Chennai municipality is facing problems or not addressing something as fully as they should, the state director can hold the councillor, the head of the Chennai Municipal Corporation, the commissioner, to account over this and tell him what needs to be done, offer support, and review whether or not what he suggested actually got done. They also support, the directorate also supports and trains Chennai's municipal public health staff. Now, every item of this is in very sharp contrast to what happens in the Municipal Corporation of Delhi. In Chennai, again, the Public Health Department focuses on the most vulnerable. On their website, they say, the main aim is to reduce health inequalities throughout the city, targeting resources, programs, and attention to high-need neighborhoods. Of course, this doesn't work as it should because they are not authorized to get, for example, water or garbage removal to these areas, but they do target their own services to these areas. This shows a very clear understanding of how you protect public health and is a sharp contrast to Delhi's focus on privileged groups, on privileged residential areas. This is one example of the active outreach of the Chennai Council's Public Health Services. They jointly organize regular camps in slums to screen for diseases, to treat people, to prevent diseases from spreading, and to improve their disease surveillance data. This is quite different from just providing routine medical services, which they do in their own primary health centers. And these primary health centers are often located near slums, so they're easy to access. But that's quite separate. This is regular camps held in slums by both the medical and the public health staff to do this kind of active outreach for disease prevention. And there's very little of this in Delhi. So one thing one can look at is what's the coverage of maternal and child health services in Chennai slums compared to Delhi slums. Well, full vaccination of children by their second birthday is 89% in Chennai and 52% in Delhi. Antenatal care. Percent of women with 3 or more antenatal visits is almost complete in Chennai and less than 60% in Delhi. Similarly with assistance at birth. Health staff assisted in births for nearly all the births, and here in Delhi for 42%. Another measure is child stunting. In Chennai, the proportion of children stunted in slums and in non-slums, there's very little difference between them. In Delhi, there's a larger difference between slums and non-slums. But really what's most striking in this figure is that Chennai slums have 28% of children stunted, and Delhi non-slums have more than that who are stunted. Now, again, it's not just because of the health services they receive. Air quality is almost certainly worse in Delhi non-slum, in Delhi, across Delhi. And there are other factors that differ, but nevertheless, to get the non-slum population of Delhi having higher child stunting than slums in Chennai is quite a statement about differences in access to preventive public health services. So what are some of the lessons from Chennai for urban public health services? One is it's important to have active outreach to vulnerable populations. The second is it's important to have a considered approach to devolution and management with formal checks on elected bodies to retain professional management of health services, minimize the authority of health elected representatives. Elected representatives, play more of a role in reflecting what people want, what their constituents want, but less of a decision-making role. And very importantly, the oversight and support by the State Directorate of Public Health. Tamil Nadu is very unusual in having this powerful technical directorate. There's obviously much scope for further improving public health services in Chennai Municipal Corporation. Just one example being they need stronger coordination with sanitation services. So the bottom line here is that public health services need effective organization and management. And some of the key parts of this need are you need the legislative underpinning in the form of a Public Health Act. If there's a disaster, you can invoke the Epidemics Act, as was done with COVID. But this does not underpin routine public health services, which is the key thing. It's important to have a budget that's dedicated just to the public health services and to have staff who are assigned just to the public health services. It's important to have a tight management structure with a clear allocation of responsibilities all the way down from state to grassroots level, and a clear accountabilities with regular oversight of all workers. And one shouldn't need to say this, but it's worth mentioning that it's important that public health services are managed by health professionals. Sometimes people think, oh, well, if you need management, what you need to do is to put an MBA in place to manage the public health services. No, an MBA does not understand the technical issues. It's health professionals who understand the technical issues. And you need mechanisms for intersectoral coordination. So to conclude, you can get huge gains from strengthening the classic public health systems, which are self-targeted to the poor, which avert costly outbreaks, and which form an integral part of development infrastructure, important for well-being, for productivity, and many things. And in organizing these public health systems, it's very important to remember the importance of how you organize things. What are the institutional arrangements? What are the management arrangements? This is often neglected in analyzing public health. Thank you.
Thank you. Thank you so much. So we have actually a few questions, four in all, and one is on the Q&A, one is actually coming through the Facebook Live, and a couple from the panelists. So let me start with the one in the Q&A, which is a COVID-related question from Vivek Parbetnaya. How effective was the public health cadre of Tamil Nadu in controlling COVID as compared to other states? And did their approach differ from those of other states? So this is a COVID specific question to you, Monica.
COVID is a disaster, classified as a disaster. And so the government of India went into disaster management mode, which it's very, very good at. When they do that, they get all the resources of the government to work. You know, they bring in the revenue department, they bring in a lot of different departments, they mobilize the private sector to produce more PPE, for example. And so they did a whole bunch of things as they normally do in the case of a disaster, and in fact, more than they normally do for a disaster, because this was a disaster on a very large scale. What Tamil Nadu did was very similar things, but they did it through their normal organization. And their normal organization is set up for bringing in not only for the public health services, but for bringing in any other services that are required to help out. So for COVID, they brought in the revenue department, the people who manage temples, other political parties helped out, and so on and so forth. The difference in the case of COVID in terms of what happened is it may have been better organized in Tamil Nadu than in some other places, but it was by and large, if you look at the case of Dharavi and so on, it was pretty well organized by and large in India. The difference is that in one situation of India, it's an ad hoc response. In the case of Tamil Nadu, it's their usual mechanisms that come into place and run smoothly. So for a disaster, you see possibly less difference than you see for routine services. Thank you.
Thanks, Monica. So the question from a gentleman called Balveer Arora on Facebook Live is a little bit on the more governance side of things. He says the comparison between a state capital and a union territory is asymmetric. Who does one blame for Delhi's poor performance? That's his question, and I'll leave that and
Sorry,
then.
could you repeat that, please?
Um, he says the comparison between a state capital and a union territory is asymmetric. Who does one blame for the poor performance of Delhi?
The comparison between the state
As
capital
as
and
in Chennai, a state capital, and Delhi, which functions as a union territory. He's not sure why. Basically, he's saying the two places are not comparable in the governance, in the sense of governance. Is his question?
well, one key difference is, as he points out, that is that while Delhi Municipal Corporation serves the state capital, they have to engage in a delicate dance with the central government for budgets and for other things, which, you know, in the case of Chennai Corporation, they have to deal with their own government. And typically you have the same government, the same political parties in charge in both the corporation and the center. So yes, Delhi has that particular problem, but for the most part, the Municipal Corporation of Delhi is precisely as it says, the Municipal Corporation of Delhi. I wonder if Rajiv Dasgupta, I see him here.
Yes, very much. He's on the
If
panel.
he'd like to respond to any of these questions.
Yes, that's exactly why he's on the panel here. Dr. Datta, do you want to respond before we move forward? Because there are already a few more questions, or do we want to bundle them? Or please do respond, then we can move on after that.
Okay, thank you. Very briefly, and thank you for the wonderful talk. The Municipal Services of Delhi is actually governed by the Delhi Municipal Corporation Act 1957, which initially was a whole lot of an empowered act than in its present fragmented, if not mutilated form. So at the very outset, the Municipal Corporation of Delhi actually had fire services. The Delhi transport was with the Municipal Corporation, and so on. And gradually these separated. So instead of it being perceived as a relatively weak organization, given that it's a union territory, or what is now the National Capital Territory, this was actually a much stronger entity than in its present form. And of course, after the trifurcation, it's a very poor shadow of itself. So it's gone through an enormous transition, which is not comparable to any municipal body in the country, to the best of my knowledge, and that has had, I mean, that's had historical context and very unique consequences. I don't know if that helps.
Thank you. Monica, should we move to the next question, or do you want to sort of?
No, please, yeah.
All right. So there were a couple of questions in the chat, and I'll read that out. So Mary Ellen had sort of some methodological questions. She asks, what is the basis of the analysis in terms of field work and the date, organizational analysis, and what are the impacts of trifurcation and the the Aam Aadmi Party in Delhi that had so much focus on neighborhood clinics. So the first question is methodological, to just shed some light on the methodology of the study. And the second question comes back to Delhi and trifurcation, which Dr. Dasgupta has alluded to already, and also on AAP's Mohalla clinics and whether that has made any difference to this.
Um, reiterate separately.
Yeah, so first question is just to shed some light on the methodology of the study. Did it involve field work? When was it done? That kind of stuff. So she wants to know a little bit more about the study itself.
Yes, these were qualitative interviews and combined with a lot of secondary information, both qualitative and quantitative. And it was done maybe around 5 years ago, but it took years because you keep going back with more questions and data collection.
Okay. Sure, Marie-Ellen, do you want to ask yourself the question around AAP? You can ask if you.
Yeah, can you hear me? Yeah. Yeah, my question is precisely linked to the methodology because I could see your data were 4 or 5 years ago. So my question is, in Delhi, there's been a lot of change in governance with the trifurcation. And I know from the work of a colleague, you know very well, Olivier, that especially for the dengue or for some management of certain disease, it has totally imbalanced the East compared to the south of Delhi in terms of its management and its health services. And the second question is, the Aam Aadmi Party had really put a very strong focus on health through Mohalla clinics. So have you followed up on this? Do you know whether it has actually created a change or not? Because what is also somehow slightly missing from the presentation, I understand that you can't cover everything, is maybe also the populations or the people's aspiration and behavior towards health services. So I don't know if it's clear.
I'll begin by answering, but it would be great if Rajiv also stepped in. The trifurcation took place just before we started the study. And its effects were already visible. It meant that the South Delhi Municipal Corporation was had a much larger budget than the North and East Delhi, and was in a position to offer better services. Again, South Delhi, as we all know, has more privileged residential enclaves than the North and the East, especially the East. Mohalla clinics are clinics. They offer health services, and people agree or disagree on the quality of care received, but the main point is that they're not really they're not seeking actively. They respond to whoever comes to them. They're not seeking actively to do disease surveillance, to report cases of communicable diseases unless they're on a particular list of communicable diseases. So the objective is largely treatment, not prevention. Rajiv, you would know much more about this, would you?
Well, the conflict of interest first. I have been for 10 years a public health officer in the Undivided Municipal Corporation of Delhi, which sounds quite rather historical and archaic at this point. But but the answer to the question certainly links perhaps to the second or the third slide that she showed at the beginning, that mohalla clinics, as she said very rightly, are only clinics. And while this government had a phenomenal mandate, instead of bringing in greater synergy among what was already a very fragmented system, as she explained, as the presentation progressed, the Mohalla Clinic created yet another tier. Now, in its concept, it's of course very attractive that it's a grassroots endeavor in a sense. It does bring care closer to people, but not in a very uniform way. It was ad hoc. And most importantly, it didn't create, and this, just as Monica emphasized, that it didn't really create or put in any forward-backward linkage. It's a standalone clinic in mohallas in where it is present. There have been very few systematic evaluations of the Mohalla Clinic. Opinions are deeply divided. Some hail it as the first, a very important step towards universal health coverage. Perhaps could be true in parts, but the fact that it lacks this synergy, and it really, I mean, the government really didn't make any efforts to cement together existing municipal and the Delhi government health services, didn't help from a systems point of view. I guess it's part of the answer. There is no complete answer, but thank you for the question.
I noticed that Dr. Tiwari is online, and I wonder if he would like to say something, because he also, he was the Deputy Health Officer for the Municipal Corporation.
Yes, in fact, he has made a comment in the chat box, but I've brought you, Dr. Tiwari, you can speak. I've opened you up to so that you can contribute. Please do unmute yourself and add in if you wish to.
Maybe you could explain that to unmute, he can press the space bar.
Dr. Tiwari, he has actually posted in the chat box that the Mohalla Clinic is only for curative services. Public health is in the domain of the corporation, and state do not have preventive services. That's the comment that he's put in the chat box to panelists, which I just wanted to read out to everybody. So, Dr. Tiwari, do you want to unmute and speak at this point? We can come back to you. Of course, there's going to be a lot of questions along the same lines.
Maybe you need to explain how to unmute.
Dr. Tiwari, there's a microphone icon at the bottom of your screen. So if you just press that, you can unmute. Yeah, we'll bring him in. We'll bring him in again because there are a lot of comparative questions as well. Dr. Pathak, Pushpa, do you want to ask your question? I've unmuted you as well.
Thank you, Mukta, and thank you, Monica, for that very broad study that you have done, and you have covered various aspects. I was particularly interested in learning a little bit more about the role of financial allocation in municipal budget towards public health services. So how do you compare financing of public health services in Chennai and Delhi? Does Chennai have higher per capita allocation for public health services than Delhi? I wonder if you have some information in that, and that would be interesting for me and for some other participants. Thank you.
We did not collect the data for Chennai. What I showed you was the per capita budgets for Tamil Nadu and the average for India, which is very similar. We did not collect that data for Chennai, and I don't see any of, I don't see Dr. Guhanandan, who was Chief Health Officer for Chennai. I don't see him on the screen. So we can't ask him. But again, on the corporation budget, if Rajiv or Dr. Tiwari, it would be very nice to get some feedback from Dr. Tiwari, but I suspect he doesn't know how to unmute.
It would be good if Dr. Tiwari could come in. He's been the chief. He's well been my mentor too, and he's got a lifetime of experience and service behind him in the municipal corporation.
Dr. Tiwari, if you press your space bar, then.
Mukta, as the administrator, can you unmute him?
No, I've tried.
Not as a panelist. Yeah.
Tried, but it's not. I mean, he has to unmute at his end. I've sent him an unmute request, so he has to accept that. Unfortunately, this is one of those webinar interfaces and not the regular Zoom call in which you can do it at your end.
Right. So Rajiv, did you want to add anything to that?
Well, I'm not too qualified to answer a budget question, but at the operational level, there are significant problems in the devolution of the budget from the state government to the municipal bodies, and one consistency that's got to be, well, if I may, on the more sarcastic note, celebrated is that it hasn't changed as the ruling parties changed. With all kinds of combinations at the center, state, and the municipal level, this problem has just not resolved. And with each regime, it's got from bad to worse. That's about the fund transfers and fund utilizations. The municipal budget broadly, as far as Delhi goes, or as far as any municipal body goes, is part its own earning from taxes and rents, and of course a budgetary grant support from the state level. For Delhi, this also means supporting a huge wage bill because of a plethora of clinical services that the municipal corporation runs, which for many other municipal corporations is actually run by the respective state governments. This, of course, is in addition to a very large number of clinical establishments that the Delhi state also runs. Therefore, the two really large wage bills as far as the municipal corporation goes are sanitation services and health services. Well, that's all for the moment.
All right. So, Dr. Tiwari, you're also a panelist now, so you can also look at the chat box and you'll see a lot of chatter among the panelists as well. And if at any time, if you want to unmute and come in, you're of course welcome. I'll move to Owen Smith's question. It's also in the Q&A, but I'd request him to unmute and ask it himself. Since we're a small group, it would be nice to hear voices. Please do ask.
Yes, thank you. Can you hear me?
Yes, we can.
So first of all, Monica, thank you for the excellent presentation. My question was because I know in some of your past work, you've looked at the Sri Lankan model and how Sri Lanka has organized its multi-sectoral preventive health system. So I was wondering if you see parallels or have done a comparison between the approach in Tamil Nadu with what we see in Sri Lanka. Thank you.
Yes, the Sri Lanka model is an excellent one. If they too keep their public health services separate from medical services with coordination at every level. the takeaway from the, well, there's so much to say. First of all, the Sri Lanka model suffered a bit when they, in 1987, I think partly in response to a suggestion from the Indian government, they devolved services to the local provinces, to elected officials in the local provinces. Before that, they had very tight line agency control. And this devolution made it a little harder for them to manage, because they had to manage with dealing with local politicians. They found ways to sort of to continue to manage as professionally as they could. For me, the real takeaway is that it seems to me that the Tamil Nadu model is really optimal in terms of its state level organization, its district level organization, and all the way through. The key area that Sri Lanka does very much better is their use of public health inspectors. They give them very thorough training for, I think, 18 months. And they are trained to really do whatever it takes in terms of public health. They are the primary actor in public health. And they're trained to operate on their own. And I've watched them in action. They operate with a lot of authority, but they are not threatening. For example, you know, if they walk into a tea shop to inspect the sanitary conditions, or they walk into a shop to inspect, you know, how it's being organized, to inspect the sanitary conditions. I've actually stood on the sidelines and observed, and the expression on the face of the tea shop owner or the shop owner is slightly that of a schoolboy whose headmaster has walked in and asked to look at his textbooks. It's not an expression of fear. It's not an expression of expecting to be abused or asked for a bribe. And it's really, it's the way in which they ensure all this works is really quite impressive, because the public is told exactly how they should complain if they have a complaint, and those are acted on. I can't talk about the whole thing offhand because you know, I don't want to take up all your time, but it would be absolutely ideal to have the overall organization that Tamil Nadu has for public health, and improve the training and authorities of health inspectors. By authority, I mean that they should feel that they themselves can do something of their own accord if they feel that something needs to be looked at, rather than waiting to be asked. And also they've now reinstated their training program for health inspectors, and that's a huge improvement. But it would be wonderful, you know, I tried very hard while I was in the World Bank to persuade people to just send somebody to go and look at, you know, their training program is right there on the web. Go and look at their training institute, go and look at how they operate, you know. It would cost what, a few, you know, a few tens of thousands of dollars. But I could never get anybody to think of doing that. Neither in the World Bank nor anybody that I talked with in the Indian government. And frankly, in both the World Bank and the Indian government, you know, They think public health, no, do you mean vaccination? You know, do you mean having the polio surveillance, sentinel surveillance? Just no concept. You know, you'd have to say, people would say to me, you know, what exactly are you talking about? As though, you know, I was being mystical or something. And I would say, look, you know, we're eating lunch. What makes you think you're not going to get typhoid from eating lunch in a cafeteria in Washington, DC? But you would be perfectly, you know, not unsurprised to get typhoid after eating lunch in a parallel place in a developing country. You know, what goes into that? Just think about it. It was frankly quite frustrating, but it would be just great if anybody at all were to go and look at Sri Lanka. Mind you, the third thing I wanted to say about Sri Lanka is that donors have succeeded in sidestepping public health in Sri Lanka. The first thing I noticed when I got there is that a huge office has been built for the Department of Maternal and Child Health. Enormous air-conditioned building with all the computer facilities and everything you could wish for. The Department of Environmental Health, which is exactly at the same level as maternal and child health in the overall structure, had 2 rooms in the old building. You know, so donors pour money into what they understand and entirely neglect what they don't understand. But nevertheless, they were continuing to function because they themselves, the Sri Lankan health people, understand the needs of public health because they've come through the districts where they themselves have managed these clinics and they understand the importance of what public health inspectors do. But the destructiveness is really quite remarkable. Owen, did I answer your question?
Yes, thanks. That was very interesting listening to you. Thanks.
Right. We'll move to the next. I'm going to thanks Owen for chipping in. We'll move to the next set. I mean, Aprajita, do you want to go? Aprajita has a set of more historical questions, and if after Aprajita, Shahana, you could also ask yours, because I think slightly different in vein, but also kind of talking about historical capacities. So Aprajita, please.
Hi, thank you for the talk. And I essentially wanted to talk about the way Chennai and Delhi historically have seen their the populations under administration. So MCD is not really well known for the way it handles urban poor populations. What is the difference that you see in Chennai? Do you think the self-respect movement and anti-caste agitations have somehow helped administration and informed administration, especially health? My second question is about unpacking professional management. So you clearly are showing this not disdain, but this a doubt towards elected bodies and how elected leaders sort of sidestep preventive services, which is, like we have learned in social medicine, is correct. But there are also studies which show how doctors, medical bureaucrats have their own biases about caste and religion, and that affects the way they administer services. So if you could just talk about both. Thanks.
Okay, we'll take those 2 and Shahana can and join in. Maybe 3 would be too much. Yeah.
Hi.
Shahana,
Yeah, so
I add to that, or would you like to keep your questions slightly separate?
No, I can add to that. I mean, it's a great question, actually. This is somewhat related, but not entirely. It's a little more factual. But I really enjoyed the talk because it's so rare to see this kind of comparative studies of how institutional design and management makes a difference. So I really enjoyed this presentation. My question was really, is this model something that has been replicated across Tamil Nadu, both the institutional design and the outcomes it's able to get? Or is this to some extent a feature of the fact that the Chennai Corporation may just historically have had a lot more institutional capacity? And then within the study, is it, within Tamil Nadu, is it something that's a big city model or something that we can think of kind of across the state? And it's sort of related again to this issue of whether how much devolution is good or not, given differences in institutional capacity across states.
Right, there's a bunch of questions there. So if I don't answer all of them, please nudge me. And again, Rajiv, please step in as you see fit. Before I answer any question, I'd like to add that Owen Smith is the only person that I've ever met in the World Bank who's interested in Sri Lanka's public health system and in general in public health. I'd like to thank him for that interest, and I wish him a lot of luck in promoting that interest in the organization. Now, turning to your question on Tamil Nadu, Chennai is a very large municipality, obviously. And it has, that means that, yes, to some extent, it has more resources than other cities, gets more attention. But in terms of overall resourcing and the supply of services, it's actually a little bit weaker than Tamil Nadu as a whole, because, you know, as a major municipality, the line agencies are a little bit on a back foot because they have to deal with the representatives. They try to curtail that as best they can, but it's nevertheless there. They can't sidestep it altogether. So that's one response. Now, in smaller towns in Tamil Nadu, it's the Directorate of Health Services that's in charge. Whoever's in charge of the district is the person who has overall charge of health in the district as a whole, not just the rural areas, but also the urban areas. And one of the first postings that a public health officer is given is in charge of an urban area, of a small town or a city. And they interface with the person in charge at the district level. I don't know if Dr. Vanaja is one of the participants, Mukta, but if she is, okay, she could speak more to this.
I don't see her here.
Okay, so does that answer some of the questions? And could you remind me what the others were, please?
Aprajita's questions were more historical. Do you want to repeat?
Sure. It was about the way, yes, and how self-respect movement of like back in like whenever it was, how it might have affected patterns today in terms of looking at populations under certain municipalities.
I can't really answer that question because I haven't studied it so much elsewhere. I have to some extent in West Bengal, but again, that's not famous for having a very rigid caste system. What I can say is that, say, in the provision of maternal and child care, I saw no evidence of caste entering the interaction between the person receiving care and the person giving care. Tamil Nadu, as you know, has a long history of anti-caste movements. I think perhaps one aspect of what you're bringing up is that Tamil Nadu tends to define itself on its own. It is not, it views through a lens what comes from the center, and it makes its own assessment of whether that makes sense or not. And that has something to do with its deciding to retain the separate services. I mean, they basically looked at this, the devolution order, and they decided, that some parts of it would be effective and other parts would not. So they made their own decision. They don't just lock, stock, and barrel adopt any suggestion coming to them. And that's partly because they have much stronger technical services, but also partly because of a history, history of social movements and how they define themselves.
My second question was about the professional management that you refer to throughout the talk. Do you mean health bureaucrats? Do you mean like MCD administrators, or do you mean the medical community?
The professional administrators in public health are people who are in Tamil Nadu, are people who are trained medical doctors. And at the end of their training, these graduates are asked, would any of you like to opt for the public health service? And as I said, 1% of those graduates are then the ones who opt for the public health track, are given some training in administration and management. It's not very long-winded. I believe it's just a few weeks, but it's just a question of how you administer the service. So they absolutely are medical professionals, and they have to be medical professionals, because no MBA who is not a medical professional as well is going to understand, what does it mean when there's a flood? What does a flood do? How does a flood pose threats to the population in terms of disease? What actions do we need to take in response to that? Is there a beginning of an outbreak? If so, what am I going to do about it? I mean, some of these public health officers say, when things get really bad, we go in and we're doctors, we're treating those cholera patients. So it's very, very important that they totally understand all the medical technical issues, both for understanding what they themselves should do in response to a public health threat, but also for very close collaboration with medical services, which they have all the time. As I showed you in the slums, they collaborate with the medical services to go in, say who's sick, check them all out, then do disease surveillance, give them training and education in, what they need to do to deal with the current epidemic of conjunctivitis or whatever's going at the time. They have to collaborate very closely with the medical services. So in every which way, it's absolutely crucial to have medical personnel who are put on that track. And I might add that in Tamil Nadu, just as in colonial India, the public health track doctors are given higher pay and faster promotion avenues. And that compensates them for, what they forego otherwise, and motivates them.
Thank you. Thanks. That's it. Thank you.
So I'd like to now, thanks, Monica. I hope this is not too tiring. There are still a couple of sets of questions, and I think that's about it, but unless more crop up. Dr. Rifat Hassan, could I invite you to unmute yourself? He has a couple of interesting questions too. You can also put your video on if you would like to. Dr. Hassan? Has he dropped out of the call?
She wants to be unmuted.
No, yeah, right. There we go. I did, and that's why
Can you hear me this time?
Yes, yes, please.
Okay, great. Monica, it's very great to see you and have this excellent presentation. I have two questions. So the first one is, we generally talk about public health services to mean prevention of infectious diseases and communicable diseases. Given the lessons that you've shared with us today, which I think is an excellent analysis of the situation in Tamil Nadu and Chennai specifically, how do you think these lessons can be applied or translated for the prevention of non-communicable diseases? So again, not from the curative side, but how can this public health system and organizational structure, what are some of the lessons that can be translated or applied, in your opinion, for the prevention of NCDs? So that's question number one. And then the second question is, given the success of Tamil Nadu in emphasizing and prioritizing public health, how does Tamil Nadu prevent the dilution of this and kind of prevent a sliding into more of a curative and clinical medical approach? Thank you.
The second question is very easy to answer because the separation of the Directorate of Medical Services from the Directorate of Public Health means that it's quite difficult to slide from a public health to a purely medical viewpoint in your service provision. It makes for a situation where you prioritize both because the nature of people's job description is very clear and very distinct. And right now I'm forgetting what your first question was. Can you remind me, please?
Yes, I was asking, given the lessons that we've learned on public health and how the services, not even the services, but the actual system and administration is organized to promote public health. And we generally talk about it in the prevention of infectious and communicable diseases.
Oh, right.
And how would you recommend translating some of these lessons for the prevention of NCDs now, especially given the increasing burden of disease of NCDs and lifestyle factors and the importance of all of that in Tamil Nadu? Over.
The simple answer is it's very easily done because you can use the same population-based focus in terms of disease surveillance, in terms of outreach to individuals, health education, outreach to actually help people change their behaviors and so on. It's very easily done. But the other part of what I'd like to say on this is that it would be a pity to do it prematurely. In Sri Lanka now, they're shifting at least their maternal and child grassroots workers, the equivalent of our ANMs, they call them public health midwives. They're having them do check people, if there's diabetes, NCDs in general, having them check for that, helping them, figure out, what their particular behaviors should be and how to change. Because they're visiting households individually, their public health inspectors are also in a position to do health education to community groups, and also in schools, all over the place. They do health education, and it's very easy for them to shift from communicable to non-communicable diseases. What I would like to say is that it would be, in my view, a huge pity to make that shift before you have finished dealing with communicable diseases or you've brought them under very sharp control, as Sri Lanka has. So they can afford to begin to make that shift now. But in India and elsewhere, I mean, there are very powerful lobbies emphasizing that, oh, there's more people, you know, now in India or elsewhere who now suffer from non-communicable diseases than communicable diseases. And so we should make this shift. Obviously, there's a pharmaceutical lobby, which is very important in pushing for that. And there's a lot of vested interest in making that push. Well, I mean, the first point is that obviously the prevalence of non-communicable diseases is higher, because if one person gets high blood pressure at age 40, they're going to have it for the next 50 years. So at any one, if one child gets diarrhea, they're only going to have it for a few months, and they're either cured or they're dead, right? So the prevalence, you know, by the nature of the exercise, is always greater for non-communicable diseases. But equally and much more importantly, you know, what should public funds be used for? Should they be used for dealing with things that people can communicate to others, i.e. communicable diseases, or non-communicable diseases? If I have diabetes, I'm not going to give it to everybody else in my household, right? Or my neighbors and other people. So it's the sheer externalities of having communicable diseases that make it really important to keep a focus on that until you have it well under control. And perhaps even longer than that. I think this COVID case has made us understand that in the Western world, where they dealt with communicable diseases a long time ago, and it's essentially a matter of the past. I mean, right now they just have to keep maintaining the service to make sure that there isn't another outbreak of typhoid or malaria, right? In places where it was endemic before. If they're faced with something, a new communicable disease, as this COVID was, their systems are really not very well geared towards doing that, because they've sort of forgotten about it. And it brings out the importance of how to do that. You know, all of a sudden they're saying, oh, we don't know how to do contact tracing. You know, that's too much. Well, the fact is they still do contact tracing for things like HIV. But they don't either wish or know how to scale it up to do it properly. A few countries that, like essentially in East Asia, South Korea, Taiwan, and so on, which have encountered, they've made the shift to non-communicable diseases for most of their work because they've dealt with the old communicable diseases. But they have more recently encountered a series of infections. So they're sensitized, and they are able, their public health systems retain the flexibility to swing into action very quickly in response and do all the contact tracing and isolation and everything that's required to kill the pandemic in its tracks. And in the Western world, that ability was lost. So, you know, it's a sort of it's a balance. And in a setting like India, where there's a high level of communicable diseases, it's just plain lunacy to shift over, you know, to say, well, we don't really care about those kids who are dying of diarrhea, or the kids, you know, whose guts are absolutely unable to process any food. What we care about is, you know, dealing with the diseases that affect us, because we're getting diabetes, we're getting blood pressure. I think that would be a real pity. Sorry for a rather long and impassioned response.
No, that's fine. If I could just come back very quickly. So just to clarify, it wasn't so much a question of prioritizing NCDs over infectious or communicable diseases. It was more of a decision of the state to when they are looking at NCDs, the prevention and the promotion versus more of a curative and treatment. I think it was coming at it actually more from that angle. But I think you've made your argument very nicely. So thank you for that. But just I was trying to get a sense of, from the prevention and promotion standpoint, which, as you said, is a much more efficient way of utilizing resources as well. How do we in Tamil Nadu continue with more of a focus on the prevention, the lifestyle behavior changes on NCDs versus sliding into more of a clinical treatment, drug management angle? That's more where I was coming from. But thank you so much.
Thank you.
So unfortunately, the asker of the question has had to leave. Dr. Partha Mukhopadhyay from CPR had a question for you, and he asked it a long time ago, but I was keeping the host's question for the end, but I'm going to ask it anyway. He asks, what does it mean when stunting in slum and non-slum is similar? Is this an example of public health compensating for socioeconomic disadvantages? And do these patterns persist in the NFHS 5 sort of survey results that have just come out?
I've been looking for those results to come out from the NHFS 5, and I haven't found them yet. So I can't answer that question. It does take a while for those publications to come out after the main report. Maybe they'll be out soon. Right, and what does it mean? I guess it means that they are providing they're providing care for these children. So that's one component. Another thing with Tamil Nadu is that they try very hard to feed everybody with their school meal program, which is legendary, with their Amma canteens, which are also somewhat legendary, but also, their PDS system works very well. With this lockdown, they had pretty effective mechanisms for getting food, home delivering food, making, cooked food available to people, not just at low prices, but sometimes for for free. But basically making sure that people get fed. So Tamil Nadu does both on the nutrition intake side as well as on the public health side, and that's probably what you're seeing reflected here.
All right. We really don't have any more questions, but there was a request or rather a question around the availability of the study and whether it's published and stuff like that. So if you'd like to sort of respond on how, I think there were a few people who wanted to know how to access, read more on this, on your work, etc.
I'd be happy to give you a couple of papers if you want to put them on your website or share them with the people who asked.
Yes, absolutely. If you could send them to me, we could put it up on the event page and, when we send it out on our social media, and it's there.
Mm-hmm.
So yeah, that's it for the questions. It went on quite long and there were lots and lots of questions. Thank you so much for your patience in answering all of them and for joining us so early in the morning in your time. And thank you to everyone who stayed till the end of this talk. Thanks, Monica, and we're really grateful to you for agreeing to do this.
Thank you. Thanks for setting it up. Thanks to Marie-Hélène and to you and Seema for giving me this opportunity and for setting it up so smoothly. Thank you.
Bye. Bye, everyone. Till the next time.